CDK7 is a really key kinase because it is central to not only proliferation, it kind of kickstarts the proliferation cycle, but also transcription, which is important because cancers have super enhancers, which are, and obviously transcription is needed to get those super enhancers activated. And not only that, in breast cancer, it also, CDK7 activates the estrogen receptor. So what I mean by that is that when levels of estrogen in the blood are very low, CDK7 kicks in, phosphorylates the estrogen receptor and activates it, so it becomes many-fold more active. So it's as if when the patient is being treated with an anti-estrogen or an aromatase inhibitor, there's no treatment at all because CDK7 is upregulated and it's hyperactivated. So for all those reasons, we began a CDK7 program 20 years ago. And we published the first prototype specific CDK7 inhibitor in 2009 in Cancer Research. And then we spent the next 5 years developing an oral inhibitor which could be taken with endocrine therapy. The idea was that we would give it with endocrine therapy to enhance its activity, okay? And so obviously that is really needed now because, as you know, all patients with metastatic breast cancer receive CDK4/6 inhibitors with endocrine therapy, and they become resistant to it very often between 6 and 18 months. That's all that they have on it. And after that, there's only chemotherapy at the moment, which is obviously undesirable. So we took this population and we treated them with the CDK7 inhibitor, Samuraciclib, and with Faslodex. Now, normally Faslodex in that situation is almost ineffective. It's got a very, very limited effect in the majority of patients. But what we found was this combination really seemed to work in lots of patients. So after 24 weeks on treatment, 35% overall of patients were still controlled, so they were still achieving clinical benefit. We then next looked to see why it was that some patients were responding and others weren't, and we measured various factors in the blood, like p53. We sequenced p53 and ESR1 and PIK3CA, and what we found was something quite surprising, and that was that if you have mutant p53, you will not benefit from CDK7 inhibitors. And then laboratory work, we actually first showed this in 2009, but we didn't quite know why. But what we found out was, or what we think is happening, is that if you inhibit CDK7, it's such a central factor in the life of the cell that it creates so much stress to the cell that you upregulate p53, which then slows the cell down and then causes apoptosis or senescence. And so that's really the fourth reason why we think this is working. So in summary, and by the way, in the p53 wild-type patients, the clinical benefit rate at 24 weeks was, I think, 52%. So it's, if you look at equivalent things like Veronica and Solar at using Faslodex alone, it's like 8 weeks. So this was very surprising to us. So in summary, we think that we have a drug which could be added to oral SERDs. We've heard about Fulvestrant this morning already. And we feel that if we add it to that or other SERDs which are coming along over the next year or two, you can really ramp up the benefit rate with the combination. And it's relatively non-toxic. And we feel it's a tablet a day. And so we're really hopeful that this is going to be important for women with breast cancer.